Going into the emergency department on a Friday night is like driving in rural South Dakota and there's a blizzard coming. But you have to make it to your destination, so you put your foot on the gas and you hope for the best. When you arrive in the emergency department, you might catch a glimpse through the doors into the core of that ER, where you see this flurry of activity, where there's nurses going from room to room, trying to take care of patients. There's lights flashing and sirens blaring, and somewhere in the middle of it all is a physician just trying to direct traffic. And you might look back in there and think, they're saving lives in there. My name is Benjamin Aaker. I'm an emergency medicine physician, and I've been doing this for 15 years. And in that time, I've had some time to develop a lot of opinions, and I'm going to give these opinions to you today. I have the distinct privilege to be able to teach all of the medical students who come through the great University of South Dakota Sanford School of Medicine. And in this 2-hour behemoth lecture that I give to them, I get to give 10 minutes of time that I think is the most important thing that I tell them. And I somewhat egotistically call it the secret of medicine. And I'm going to reveal that to you today, just as I do for them. But first, a word of caution. Some of the things I'll talk about are kind of some difficult topics. And I'm not going to show you any gruesome pictures up here. But if you are a person who gets a little bit squeamish at the mention of bodily fluids, now might be a good time to exit the room, relieve yourself of some of those bodily fluids, and then come back in 15 minutes for the excellent talks that are to follow. For the rest of you, let's strap in, keep both hands on the wheel, keep your eyes on the road, and let's learn how to save a life. Students, future colleagues and physicians, you've come so far, and now you may feel like you've made it, but you're only in second year of medical school, and you've got so much more to learn. Back when you were in undergraduate school, you were studying hard, and while your friends were out partying, you were studying organic chemistry. And you studied and studied, and you applied, and finally you made it into medical school, and now you're here. And you may feel like you actually made it, but you haven't yet, because you've still got 2 more years to go. And now all of the times where your friends are out starting families, you're now studying pathology for those Monday morning examinations. And you're going to get through this. And once you get through, you're going to graduate and they're going to call you doctor, but you still won't have made it yet because you'll still have so much to learn. Because all of those things that you've been doing, all this textbooks and exams and studies are going to give way to 3 a.m. phone calls and difficult decisions. And you're going to get through those 3 years, 5 years, or 7 years of residency and fellowship, and then you're going to graduate and go on your own, and you're going to be making those difficult decisions on your own. And you may think like you made it then, but you still won't have, because you still have so much to learn. And I'm so sorry to do this to you, but I need to tell you this, because the average physician coming out of residency is going to see 3,548 patients over the course of a year. And you multiply that by the average career span of a physician of 30 years, that comes out to 106,440 patients. That's 100,000 touch points with which you have to make a difference on the patient, so you better make it count. And you may think like that 100,000 patients is really a lot, but when you go outside after that blizzard in the morning and you go look at your makeshift rain gauge that you have out there, you line up 5 of those in a row, you'll have 100,000 unique individual snowflakes right there. And that might seem like a lot, but when you look out past that into the lawn outside, there's some 8 billion snowflakes that you have no hope of touching or moving in any way, and that may make you feel very insignificant. And I'm so sorry to do this to you, but it's going to get worse. Because of those 100,000 patients you're going to see over the course of your career, a full 95% of them, or 95,000 patients, will get better, no matter what you do. These are the patients that come in to see you and they have chest pain and shortness of breath, and you listen to their story and you do the examination, and then you diagnose them with a rhinovirus, the common cold. And you know the immune system is going to fight it off better than anything that you could possibly do. Sure, you could do stuff to them. You could give them an antibiotic. Don't do that, this is a virus. You could give them an antiviral. Don't do that either. It's not going to work for this, this is a common cold. You could do anything that you want. You could give them an anti-inflammatory, antiemetic, antihypertensive, anticholinergic, antispasmodic, or an anticonvulsant, or you could give them a pat on the back and a drink of water and tell them that it's going to get better, because it is going to get better no matter what you do. And that may make you feel pretty useless. And I'm sorry to be the one to tell you this, but I think that you need to know this. You may have heard, or you may have thought where this is going to go. But of those 100,000 patients that you're going to see over the course of your entire career, 3% of them, or 3,000 patients, are going to get worse no matter what you do. These are the patients that come in to see you with chest pain and shortness of breath. And you listen to their story, and you listen to their lungs, and something doesn't sound right, and you do the examination, and you go to a chest x-ray. And once you get the chest x-ray, you look at it, and you see this big lung mass on this side. And because of all the education that we've given you, you know that this is an advanced stage lung cancer. And while not everybody with advanced stage lung cancer dies, the patient in front of you will. And you will feel so bad about that. And you will do everything that you can for them. You will give them radiation, you will give them chemotherapy, you will give them immune modulating drugs, you might even take a scalpel and remove that diseased lung from their chest. And despite all that, they will die. Or they may come in to see you with chest pain and shortness of breath. And they come in and their heart is stopped and they have the widowmaker, the big one, the MI, the heart attack. A blood vessel in their heart is blocked and it's caused their heart to stop. And you will put a tube in their throat to breathe for them. You'll put them on a ventilator. You'll do chest compressions, CPR to try to get the blood flowing. You'll give them epinephrine, a stimulant to get the body moving. And you might even give an electrical shock. And despite all that, your patient will die. But you might come into the emergency department for a 3 p.m. shift, for the evening shift on a Friday night, and start your work. And when you get into the emergency department, you hear a commotion coming from critical care room 1. And you go into that room, and just as you're going in, your partner who's going off shift is coming out, a tiny bundle in his arms. And you go into that room, and you see the patient on the bed who is his patient, but now your patient. You're taking over, and a nurse is doing chest compressions, giving this patient CPR, and another nurse gives you a briefing. This is a 25-year-old woman who was recently pregnant. She was 38 weeks along, full term, getting ready to deliver. She was sitting on the couch with her husband, and she was complaining of chest pain and shortness of breath, and suddenly her eyes rolled back in her head, and she collapsed onto the couch. He called 911 very quickly, and they arrived, and the paramedics did a great job. They put a tube in her throat to breathe for her. They did chest compressions. They gave her epinephrine, and they brought her into the emergency department. And your partner will have done everything that he could to keep her alive, but he realized that it wasn't working, and he needed to do something else. And so he made a decision to do a procedure that some of us will never do over the course of an entire career, or maybe do once, the Perimortem cesarean section, a C-section that we do to deliver the baby when the mother is dying. And you see, we know that when the mother is dying, that she will divert the blood flow to the uterus, to the baby, to try to keep her alive. And this is this last act of compassion that she is doing. But we know that without the mother's heart, the baby has no chance of survival. And so if we can deliver that baby, we might just have the possibility of saving them both. And so you'll come into that room, and your partner will have done this procedure. And you'll walk in there, and the chest compressions will be given to this person, this human being on the bed. And now your hands are inside of her, trying to stop the bleeding, pushing on blood vessels, tying blood vessels, and you're calling for blood. Type O negative, the universal donor. How much blood? Keep it coming. And you're tying and you're squeezing, and they're giving blood, and as with every chest compression, it's going out onto the floor and onto your shoes. But this is a life that you must save, and you will do everything that you can to save that life. And so you keep on going, and you're giving blood, and you're tying and you're squeezing, but it's not working. And so you call the obstetrician to come down, and he comes down very swiftly and says, "How can I help?" And you take a second to decide, and you say, "Do a hysterectomy. Remove the uterus that's bleeding so that she can stop bleeding." And in that instant, you've made a decision now that she'll never have a child again. You make that decision, and he does his job skillfully and expertly. He removes the uterus, and you're squeezing, you're tying, and helping out. She's still bleeding. You're calling for blood, and you're squeezing and tying, and you're calling for blood. Where is the blood? And the nurse comes up behind you very quietly, puts a hand on your shoulder, and says, "Dr. Aaker, Dr. Aaker, there is no more blood. You've used up every unit of blood in the hospital." And at that moment, you will realize that there's nothing more that you can do, and she has died. And you'll pronounce her dead, and you'll take that longest walk out of the emergency room to the family room that's so inappropriately named because there's only one person in there, a father and a husband. And as you walk out the room, or into that room, you see your partner who's going in the same direction. And you give him a look that says everything. And he gives you a look back. You go into that room, and you sit down and talk to him, and you will do everything that we taught you in medical school. You will treat him with compassion. You will show him empathy and kindness. You will answer all his questions, and you will use concrete, understandable terms when you tell him that that day he lost both his wife and his daughter. And at that moment, the tears will want to come, but you'll fight them back because you believe that's what a physician does. And you will answer his questions, and you'll give that compassion and empathy. But when all the questions are answered and all the compassion is given, you're going to exit that room wishing him the best, because it's 4 o'clock now, and patients have been waiting for an hour. So you put this fake smile on your face, and you go out there and you lie to every one of them that asks you how your day is going. But you're going to get through it, because that's what a physician has to do. And once you get home that night, you're going to go to bed, and at 3 a.m., when everybody in bed is alone, one thought will come to you. How many people did I deny life today when I used up every unit of blood in that hospital for this one patient that I thought was mine to save? And at that moment, the tears will want to come, and I believe you better let them. And there's going to be hard moments like that in your future career, and they're going to keep coming. And you better have tears when you need to, and you better seek help when you need to. And believe me, it's okay as a physician to do that. But please don't despair, because after all that, that leaves 2% of patients, or 2,000 people, over the course of your entire career that you can make a real difference for. And when you save a life, you will feel so good. These are the patients who come in to see you with chest pain and shortness of breath, and they have time to talk to you. You sit down and talk to them. You hear about the story. The patient's name is Jerry. He's got a family. He's a farmer. And as you get up to do the examination, suddenly his eyes roll back in his head and he falls back in the bed. You check his pulse. There's none there. You look at the monitors showing ventricular fibrillation, a deadly rhythm for which, if you do nothing, he will die. So you take those pacer pads or those defibrillator pads off of that machine, the nurse charges it up, and you put it down on his chest, and with a voice that you never knew you had, you yell, "Clear!" as you send 200 joules of energy through his chest, through his back, and through his heart. Suddenly his eyes open up, and he looks around with a confused look and says, "Doctor, why did you just hit me?" But you don't have time to laugh or tears, because you're out there calling to the cath lab right now to make that phone call to get him up there so they can open up that artery that's blocked and give him life. And you'll feel so good about that. But I'm sorry to tell you this, because while it may feel great to save those lives, that is not why you're here. Believe me, it's a great thing to do, but look out that door right now, and people are saving lives out there all the time with a fraction of the education that you will have when you're done with this today. Now, it's no less heroic or no less great to save a life whether you have that education or not, but there are law enforcement men and women, firefighters, police officers, servicemen and women, teachers, and yes, even lawyers saving lives all the time. And that's great. But that's not why you're here. You're not here to save the lives of those 2%, but the reason that you're here is so with the education that we give you, when you're done, you're not necessarily going to be able to save those lives, but you're going to know who is that 2%, so that you're no longer using up every unit of blood in the hospital to save that one life that died 15 minutes ago, so that you're no longer using up every antibiotic in the community to treat the common cold. Never forget that you're not useless to those other 95% of people that come in, that they're going to get better or worse no matter what you do. You can still heal their pain. You can help them with their suffering or their depression. When they lose a loved one, those people now become your patients, and you can help them through their sadness. And you can also help yourself when you need it. And when 3 days later, Jerry comes down from the hospital, walking on his own, no longer a patient, but now a visitor, just wanting to come down to the ER to shake your hand and say, "Thank you for giving me 3 more days with my family." You'll walk out there to shake his hand. You're going to look back into that room and that blizzard of activity in the emergency department. You're going to look at him in the eye, and you're going to lie to him when you say you're welcome. But it's no problem at all. We do this every day. Thanks for listening.